Hello, everybody. We are ready to get started with our presentation. We're very pleased to have Brenda Fitzgerald here today from Uxbridge Orthopedics, and she and Cheryl are going to talk a little bit about sciatica. Okay? Welcome.
Thank you. All right, for those of you who were here last month when we came and spoke about the frozen shoulder, I apologize now. I just want to let you know we're from Uxbridge Orthopedic and Sports Therapy. We're connected to the Lydia Taft House. That's where we're located. We're in the same building as them. We, Cheryl and I, do outpatient physical therapy only. They have different therapists who treat over at Lydia Taft. I mean, they're very lovely. And if your needs require physical therapy, one of the things that the Senior Center does with their bus is they offer rides to your physical therapy appointments. What happens is if you need physical therapy, you call us, and then we call the Senior Center and arrange the schedule based on what the bus is free to do. So you have very little work to do. In addition, I always like to mention that there's the Lydia Taft House has a free exercise class on Thursdays called PACE. There's some paperwork to sign. I should have brought some. I didn't bring it, but you can take my information and I'll get it to you if you want. But it's free. It's funded federally by the government. And PACE stands for People with Arthritis Can Exercise, and the bus can take you to that too. It's every Thursday, so there's several people who go from here, actually. So if you have questions, just let me know. I know Jeanette goes. But it's a fun group, right? Don't you think? It's a good group. All right, so anyway, that's done with the business. Yep. So sciatica, a real pain in the butt. I thought it would be a little chuckle to say that. So sciatica is a term that's very difficult for us medical people to take in. What I do when I hear a patient has sciatica, either it's written by a physician on the doctor's order or they say they have sciatica, that just kind of gives me a sense of where their pain is. But the sciatic nerve starts to develop somewhere near your fanny. So to truly get sciatica, you have to irritate it down there. It's not coming from your back. Though there are many other symptoms that do come from your back that mimic sciatica. So the common thought of sciatica is pain maybe in your back, mostly in the butt cheek and going down, usually the back of the thigh. But like I said, there's a lot of alternative diagnoses, and how we treat it depends on where that nerve pain is coming from. So my goal today is for you to understand the difference between sciatica and other things that exist that are similar, but we would treat differently. So we need to figure that out when you're there in physical therapy. So the first thing that you need to know is the anatomy of the spine. You've got all those vertebrae that are like bricks piled up in a tall pile. And in between those bricks are discs. Those are like gel-filled cushions, and they give you shock absorption. As we age, we dehydrate a little. So those discs, kind of like a flat tire, it just kind of loses a little of that gel or dehydrates a little. So the space between the bricks is a little less. And that becomes a problem in the anatomy. The vertebrae are bones. They have a round component to it. That's where the disc sits. But then they have this arch along the top. And some 3 projections. And if you look at that picture on the first page, you'll see what I'm talking about. Those 3 projections out, I remember my neuroanatomy professor told me it looks like a house. You've got this roof. The point of the roof is what you feel when you feel your low back. That's that bump back there that you feel. The 2 on the side are similar in size, but you don't really feel them because you have muscles layered on top of that. So you don't really feel those. And then the base of the house, the real part of the house, is where the disc sits. And then the other thing you need to know, which is why I put it also on the picture, a different view, is the side view of it. You'll see there's a little bit of an arch to it. That creates a hole with another vertebrae, and that's where the nerve roots start to come through. And I said nerve roots because that's different than a nerve, and I'll get to that in a minute. So sciatica, or low back pain that goes down the leg, really, usually comes from the symptoms in the low back area, the last 5 vertebrae or so, in the small of your back. But what it really says to us is there's some traveling pain, so there's probably some nerve involvement. So you've got some nerve, is the second page there. You need to know what a nerve does. Nerve basically has 2 main functions. It gives you sensation. When that part malfunctions, you'll get the tingling, the numbness, the pins and needles and things like this. And this is all nerves. Any nerve in your body does that. But it also provides electrical power to your muscles. So when that part malfunctions, you have trouble moving. For example, I ask you to pick up your big toe, and you can't. Well, clearly that doesn't hurt your low back to do. That just tells me the electrical signal is not very good down to the nerve that supplies the big toe. So a lot of our exams at a doctor's office or a physical therapist's office, we're doing leg strength testing, and you're thinking it's not my knee. This is why, because we're actually looking at different nerves and making sure the connection is there. I often describe it like a bad electrical circuit. If you think of a frayed wire, if there's pressure on that wire, then the light bulb doesn't light up very well, right? It's a dim light bulb. So it's the same in the human body. So we're looking for weaknesses, but we're also going to ask you questions about numbness and tingling and pins and needles. And both of those things, the weaknesses as well as the sensation part, have very distinct patterns to them. We've had to memorize those in school. For example, one nerve root goes to the front of your thigh. So if you're having tingling in the front of your thigh, I know which nerve root that is. So then I can trace that back to, could it be that disc? And then my assessment goes on from there. If it's on the back of the thigh, it's a different nerve, so I need to look at a different thing. So as we're examining you in the medical field, that's why we're doing what we're doing, or that's what we should be doing anyway, and if you haven't had that. So that sensation versus the electrical power, you can have a malfunction in either or both. So we're always asking questions. Do you have numbness? Do you have tingling? Let's test your strength and see where your problems are, because that's collecting data for us and we're figuring you out. So the sciatic nerve is one nerve, but in reality, it comes from several nerve roots. So you heard me say that between each vertebrae, right off the spinal cord, comes a nerve root. Later down the line, it braids up together like that rope I have pictured on the slide. Several fibers of different nerve roots make up the sciatic nerve. So I could have a problem at the nerve root that feels like sciatica, but it's not. The problem's at the nerve root. But because they contribute to the sciatic nerve, it makes it a little more confusing. So that's what makes our job a little more challenging, to try to figure out, is it coming from right at the spinal cord, or is it coming from really truly where the sciatic nerve starts to braid up together and form? So what is sciatica? It's pinching of the nerve, or probably most commonly it's really those nerve roots that are the problem. And like I said, our examination is about where we need to treat based on where we think it's getting pinched. So at the spinal level, it could be things like degenerative arthritis, or it could be that flat tire disc. We call it degenerative disc disease. A doctor will write on a piece of paper a referral to us, DDD, that's what that stands for, degenerative disc disease. Arthritis, it could be a herniation or a rupture or a bulge, and it will push on that nerve root and give you all those same sensations, but it's not sciatica. At the muscular level, near the butt, is a muscle called the piriformis muscle. It's a deep butt muscle, and that actually, when it goes into spasm, can actually push on the actual sciatic nerve. And to me, I don't know how Cheryl feels, I haven't checked in, but to me, that's sciatica. That's when the sciatic nerve is actually getting irritated. Everything else is coming from the spine, so it's a different beast to me altogether. So the treatment for that would be, obviously, we've got to figure out how to calm down that muscle. be it my elbow or other weapons of mass destruction we use. So let's go to the more common cause of what everybody assumes is sciatica, and that's really usually those discs. So if you go onto the page where it says disc problems, just so you know where I am, I want to describe a few different things that discs can do. So I want you to think, this is Cheryl's, I'm stealing this from Cheryl. The disc is like a jelly donut. It has an outer coating and the goo on the inside is there, and it helps give you shock absorption between your bones and everything. I already said to you, we lose a little of that goo, it dehydrates, so you get a little less shock absorption. What can happen are things called bulges, herniations, rupture. There's lots of different words, but I'm going to go with the three basic. So a bulge disc is kind of what it sounds like. That outer section of the disc has just protruded out, but it's still intact. The gel is still sort of where it belongs. It's kind of like a pimple. It's just kind of poking out a little bit. It may not be touching on the nerve. The mere fact that you have a bulge disc does not mean that you have back pain. It doesn't mean it's the cause for your back pain. The only time that it is the cause of your back pain or the pain going down your leg is when it's actually touching the nerve, because the disc doesn't have a lot of sensation. So a bulge disc, and I will bet you 80% of us in this room have one right now, may feel like nothing. You may not even know. When MRIs first came out about 25 years ago, they did a lot of research, and they did one big research. I was working at Brigham and Women's at the time, and the research was done there, so I knew about it. They took 400 non-symptomatic people without back pain, and did MRIs on them. And it was like 70% of them had bulge discs. They had no pain. So then they had them kind of move around, wiggle around. They did a repeat MRI and the bulges were gone. So they think the bulges are more positional. And what they found was the people in pain were the ones that something was touching the nerve. The disc was touching the nerve. So don't panic yet if you have a bulge disc. It's okay. What I do when I look at an MRI is I say, okay, but is it touching the nerve? Because that's all I really care about. So a herniated disc, there's several rings in that donut. Let's say there's several layers of donut material between the gel and the outside of the donut. Some of the inside layers have started to rip, and we'll see that on an MRI. The disc, it may be pushed out more or less than the bulge, it doesn't matter, but we're actually seeing some rips of those inner rings of the disc. And then the rupture is the outer ring. So the jelly's actually squirting right out. So any one of those can create a problem for the nerve. But again, I'm looking to see, is it touching the nerve? That's all I care about. So a lot of people will say, oh, I have a bulge disc. I'm like, that's nice. Is it touching the nerve? So that's really where the pain comes from. So the one thing I should say is, can you have a bulge disc and make it go away and unbulge? Yes, you can. Can you have a herniated disc that regresses and gets better or progresses and gets worse? Yes, you can. And again, the key focus for physical therapy is getting it off the nerve. That's really what we want to do. All right, so pressure on the nerve directly, not at the spine, is that piriformis syndrome. And you can see on the picture where that muscle is. It's basically at the small of your back, and it comes off at a diagonal over toward the hip. So it's a small muscle relative to several of the other muscles there, but it happens to sit right over the nerve. So when it goes into spasm for several different reasons, it will just literally physically push on the sciatic nerve and give you true sciatica. So obviously our treatment's focused a little bit differently on calming down that muscle versus working on the disc and the space between the spine, the vertebrae. So the causes and solutions, if it's pressure on the spine, be it from arthritis or the disc or what have you, physical therapy is going to work on things that help reduce the inflammation. Sometimes that inflammation comes from repetitive use. You're always sitting all day, so you're kind of leaning on that disc a little bit and kind of pushing it out because of the postures. So we'll talk about posture and sitting upright, and it only hurts when I'm sitting on my couch, okay, let's look at that. How are you sitting? Are you all slumped up because it's a soft couch? Can we put a back support back there and straighten up your spine? Are you crossing your legs? That will cause a problem, things like that. So we're looking at how you do what you do. How do, you know, I had a patient this week that said, my back is killing me, I don't know why. And she said, all I did was, in preparation for the holidays, I was baking for like 6 hours. And I'm like, okay, so you were baking for 6 hours? I think I know what's the problem here. So it's talking to her about, could you have done some of the stuff that you were doing sitting? Just give your spine a change of position. I talk a lot about people opening up the lower cabinet and putting your foot up, or put your foot up on a stool. That changes the angle of your spine. Can you do the baking, but do it just a little bit differently to take pressure off the discs and the spine itself? So a lot of therapy is about that, teaching. I have a few in the audience who will know that. I spend a lot of time teaching so that this doesn't come back. When it's piriformis syndrome, we will work on the muscle. I often, as some know in the room, I'll lean in on that butt muscle right with my elbow, the pointy part of my elbow. Works like a charm. They love it. No, they don't. One of the things we do advise, particularly for men, is the wallet. The wallet, if that wallet's back there, it's right on that muscle. You've got this big, in some cases, thick wad of pressure, and you're sitting on it. You're just shoving that right into the nerve. So we'll tell people to move their wallet to the front. That really often makes a great difference in the pressure right on the nerve. And again, bad postures, crossing the leg here too is really bad. That stretches that muscle. So that muscle on stretch will compress into the nerve and create some of the problems. So crossing at the ankles is fine, but crossing at the knees is a no for these people. Now, disc pressure, there's been tons of research, but that next picture that I show you gives you an example of how the pressure in the disc changes with certain activities. So coughing and straining, which we all do, we don't have a lot of control over it, can go anywhere to 5 to 35% increase in the pressure on the disc. That means it's going to want to bulge. It's going to want to squirt out there, right? Laughing, 40 to 50% increase in the pressure inside that disc. Walking, 15. Not so bad. How many of you with back pain said, you know, I can walk, it's not that bad. It's laying down in bed that's a killer. Or coughing or sneezing and those kind of things. Bending to your side, 25%. That plays into part when you're getting up out of bed. How do you do that? Do you go onto your side and then lay down? Or do you go like this? There's much more pressure on your back when you go the wrong way. So we'll teach you that. A small jump. I know you're probably not doing a small jump, but 40% increase in your disc pressure. But if you put that related to lifting something with your knees straight and your back all bent, 169% increase in pressure. So doing things the wrong way really, really, really can screw up your back, is the bottom line. So that's why we spend so much time trying to say, bend your knees. This is why. I mean, even if you just bend your knees, now you're down to 73% increase. And I think the big misnomer is that it doesn't have to be, and rarely is, that you have to lift up something heavy to create back problems or the sciatica type symptoms. You could pick up this piece of paper off the floor and ruin it. And most of our patients, that's exactly how they get to us. They're like, I didn't do anything. All I did, I picked up a pen and and it's really about the how. And that slide in particular really shows you that the how is very, very important. So if all you learn in physical therapy is the how to do something, I love when my patients ask questions like, it hurts when I get in and out of bed. All right, let's go over that. Let me show you how you can do that without causing back pain. And then I'll say, if you have more questions, shoot. One of my common ones to help with the posture, because it's hard, it's easy to slouch. It's totally easy. I do it. I'll say, if you drive a lot, and this has saved a lot of policemen who are sitting in their cars a lot. I'll say, go into the car right now, sit there with the most perfect posture, bring your seat to you, set your mirrors the way you like your mirrors set. And from now on, if you can't see in the mirror, it's because you started to do this. And so that's your kind of constant reminder, like, oops, I'm slouching. And it works like a charm. So there's lots of little tricks up our sleeve that the therapist will give you. You just have to ask, how can I do this without causing back pain? This definitely gets me. So the more you give us, the more we can give you back. All right? All right, so now what? So one of the most common questions is ice versus heat. I've done on our Facebook page, for any of you who are into the electronic world, I did a whole article on when to use ice, when to use heat. My general rule is after you acutely injure somebody, 48 hours, it should be ice, the first 48 hours. After that, you can start to go either way. I often will tell my patients, trust your gut. You know, if you're like, I really want to use heat, that always works for me, go for it. But not in those first 48 hours, because the heat in the first 48 hours can increase the swelling in the area, and that's a definite no. But afterwards, you can start to play with it. Some people will mix it and do 10 minutes heat, 10 minutes ice, back to heat, that kind of thing. That's called contrasting. It works really quite well with some injuries. Do you stretch or do you rest? Do you move or not move when you're in an acute inflammation? The common response is, I did nothing. I didn't do my exercises because I was in pain. Well, in fact, a lot of, particularly the exercises we're giving you, if we've met you already, a lot of the exercises are meant to reduce your pain. So some of them will be very simple. So if you're going to physical therapy, or if you do go to physical therapy in the future, ask your therapist that question. Now, which of these, when I'm in pain, should I do, and which of these exercises should I not do? As a general rule, I would answer, try everything. But if it increases your pain, don't do that one. Go to the next one. But there's some that will loosen things up for you that will be very beneficial. The other thing I often do is patients will come in and go, oh, it's really bad today. Okay, let's come on in and we'll do our treatment and everything. And I'll start right with exercises. I'll do some and they'll say, oh, it feels better. And I said, look, all we did was exercises. You can do this at home. You know what to do. Notice what my choices were. We didn't do this because I thought it might increase your pain, but we did do these ones, and look, it calmed you down. So remember that. Sometimes movement actually reduces your pain, given the right exercises. Further testing. If physical therapy is not working, or we're not happy with how you're progressing, sometimes you'll need further testing. And generally speaking, the first test that they'll do is an x-ray to make sure, yes, you have arthritis, or and there's a spur leaning on the nerve, so that's probably it. Or they will look at the spaces. Remember, in an x-ray, they only see bone. So they're going to put up that x-ray and say, oh, it's probably the disc. That's not because they saw the disc. They're only seeing the bones. But what they do see, like the picture on the left of the x-ray versus the MRI, you'll notice there's a space between the bones right there. So you're not seeing the disc. That's where the disc would be. But when I look at that picture on the left, I'm seeing a lot of spurring. It's not a completely square brick. There's like these little things hanging off on all the corners. That's an old back. But I'm also looking at the space between each one. If you notice that one of the top ones has a nice big space, the next one's pretty good, and then all of a sudden there's almost no space in between. So that's where the disc sits. So I'm thinking something's wrong with that disc. I can't see the disc on an x-ray, but I know something's wrong. There's definitely a flat tire going on there because those bones got really close to each other. I'm also looking at the holes nearby to see if the holes are all about the same size as well. Now the MRI to the right on that same picture, now you can see the discs. So you're seeing a side view of a spine right there, but those little white blobs in between, those are the discs. Now, if you look carefully, that super white line going down, that's actually your spinal cord. If you follow on that picture, the white line all the way down, you'll see an area where it turned black. That's because the disc is pushing on the spinal cord. That's the disc. So that's a ruptured disc right there. It's just totally obliterated. It's totally pushing on the spinal cord. The spinal cord is now totally squished. So that's why it's black. That's the disc material you're seeing out there. So when I look at that MRI, I go, oh God, I hope I don't have to treat that. Because that's going to be a hard one. All right. So, questions. Does that make sense? There's a little bit of a difference between what everybody thinks is sciatica versus what is more common usually in the disc realm or the spine. And then that makes a difference in terms of how we treat you. You can still say I have back pain going down my leg, but I'm going to evaluate the whole thing and try to figure you out. Why is that happening? So questions. Anybody have questions? Yes, ma'am.
When I had my second MRI, my second turn with the sciatic, the doctor told me my disc was disintegrating. Mm-hmm. Now,
that's the flat tire.
If that goes away completely, am I going to have pain? Or?
You could. What happens if you lose all the jelly in your donut and those bones get really close together, you can't inject jelly. That would be really nice. They've tried things like that before. But so yes, your bone can go right to the top of the other bone and there's no cushion in between. What often happens when it gets that significant is actually the bones start fusing together. And then there's no movement at that one segment, which is not a bad thing. I have a brother-in-law who had that happen, and the doctor said, if you can handle the pain, let's just hold on and let it fuse, because then there won't be pain because the movement's not happening. So that's not good. Yes, ma'am.
Brenda, when you said about the tingling in the thigh, what if the tingling is more pain than tingling, you know?
And so if somebody comes to me and says, I have thigh pain, and I know Cheryl does the same thing, but when I look at somebody and they come in and they have thigh pain, I still look at the spine to make sure, but then I also look for other things. I look for knee problems because that's a major knee muscle there. And I start asking deeper questions like, how did it happen? When do you feel it? Oh, I feel it when I'm going downstairs. Okay, that has nothing to do with the back. That has everything to do with the knee and weakness and things like that. So when I do any evaluation, I either look at everything from here down or everything from here up. So if you come with shoulder pain, I'm going to make sure the neck is okay because the neck communicates to the arms just like the low back communicates to the legs. So I kind of try to rule out those things. We both do. I know we do. So I would rule that out. And you wouldn't have had to necessarily say that. I'm going to do it anyway because I need to make sure that what I'm going to plan for a treatment is going to work. That is my goal. Yes?
When you can go and get like, I don't know if they call it a cortisone shot, but you get the shot with, does that fill in the spaces?
No. You mean the shot in the spine? Yeah, so like an epidural shot. Remember I said the donut has layers around it? So does the spinal cord. One of those is the epidural layer. There's a subdural layer. There's lots of layers. Our brain has layers protecting it as well. So the epidural shot means that the shot went all the way through to that layer. That's what that tells me. So all it's doing is an anti-inflammatory. It's trying to reduce the swelling. That might back off the disc a little bit, potentially, or the pressure on the nerve really from the swelling, but it won't give you more gel. It is, but it's a helpful one sometimes. We both have had patients, regardless of the body part, where we'll say, go get a cortisone shot, because if your pain is reduced because of inflammation, and now I can do more with you, I can actually get some success. I can make some gains with the treatment. So I know, I mean, I've had shoulder patients. I've said, all right, can you please ask them for a cortisone shot so I can get some stuff done here? So cortisone's an anti-inflammatory. Just so you know, by the way, cortisone is also pretty tough for diabetics. So if you're getting a cortisone shot, you want to really watch your blood sugars. It's going to change your blood sugars. So it's okay to get it. You just have to be very aware and watch your blood sugars because it is going to go up. Yeah, it's going to screw it up. Yes, ma'am.
Aware of that, right?
So you said leg pain doesn't mean that you have sciatica.
Correct.
What if you don't have leg pain, it's just in your butt cheek?
Just in the butt cheek. It could be that piriformis syndrome. So I'm going to look, those are all hip muscles there actually. So I'm going to look at the hip and make sure. The hip joint, a lot of people think is right here. It's not. It's deep in here. So pain here is not hip pain in my world. I know it is in your world, but that's more a bursitis kind of thing. The hip joint, people will come and say, oh, it's a bad hip. I just don't want a hip replacement. Like, where does it hurt? Right here. Oh, you're not getting a hip replacement. The joint's deep in the groin here. So I'm going to look at all those parts and just check your hip, check your spine, see if it's more muscle or if it's referred from the nerve root. Like I said, there's patterns to all those nerve roots. And so I'm going to look for patterns. Any other questions? No? Okay. The only other one thing I want to tell you is we do free injury screens at our place. They're only a quickie 20-minute appointment. You do have to call and schedule, but I'm willing to look at something like a leg pain and give you my quick thought on what it is and what we need to do. Like I said, schedule it. You call, you just say, I want a free injury screen. I'll take a quick peek. If it's not a big deal, if I'm not seeing any major medical emergency, I'll say, oh, this is nothing. You just need to stretch that muscle. Here you go. Just do that. If I think it's something bigger, then I'll tell you. And I'll say, you know what? You need to see a doctor. You need to get x-rays. You need this. And I'll send you on your way. But we do those. Both Cheryl and I do. So you're welcome to do that. You just call our office and say, I want one of those free screenings, and we're happy to do that. Okay. All right, I think that's it. I talked really fast. All right. Thank you.